Thank you very much. When I heard some of the previous presentation, Kevin, I thought about giving you the quote from Churchill, because in the revision of a bypass, success consists from going from failures to failures without losing your enthusiasm. For next time. So, I want to tell you about the duodenal switch, and it looks like, if you look at the statistics, in the United States, it's less than 1%. So why are we talking about less than 1% procedures? You know, let's go home. And I told Robin, a few months ago that duodenal switch is the procedure that has the highest rise in the last 2 years, and people didn't believe that. Well, actually, in the last 2 years, the number of duodenal switch, if we encompass SADI SIPs, have increased by 50%. And it's the only procedure right now that is increasing at this rate. So there's, people are revisiting this operation, probably because the options of sleeve gastrectomy, weight loss failures, and diabetes coming back, maybe it is time to revisit that. So we've started a series of consensus conference. We had one in Quebec City in 2016. Some of the preliminary data were published in this journal, and the real scientific one will be published in SWORD. And then we had a second conference in Niagara Falls, and for those of you who are interested, we have upcoming one May 17, 19 in Montreal. We have 8 live surgeries which have complete duodenal switch and revisions as well as conversions to duodenal switch. So this is part of the program for those of you who want to learn duodenal switch. Now some of these pioneers appear here. You've got Picard Marceau, who is no longer comes to meetings, and then Doug Hess, and then also Aniceto Baltasar, who was the first one to do this open in Europe. And if we look at the concept is a parietal cell gastrectomy, not a sleeve gastrectomy. A lot of people think that sleeve gastrectomy comes from that, but you know, you look at the papers and it's a parietal cell gastrectomy, and the reason for that was to decrease the acid load to prevent ulcers at the anastomosis, because the problem with Scopinaro's procedure in a distal gastrectomy was that the ulcer rate was quite high, 12% and higher. Also, the common channel is at least 100 centimeter, and the total length between the stomach or the duodenum and the colon is 250 centimeter. So here's the one of the original presentation from Picard Marceau, this new type of gastrectomy, and if you look carefully at the detail, this is a 65% parietal gastrectomy along the greater curvature, and there's 250 centimeter. That's from the ileum to from the ileocecal valve to the duodenum. So not the sleeve gastrectomy that we do now, and this has implication when you do the bowel procedure after a sleeve gastrectomy that has such a small volume. That's why I'm talking about the original paper. Now let's look at Hess. What did he say about the stomach? And the stomach is actually, was done over a 40 French dilator, but it is done with 1 to 2 fingers from the dilator. So you're talking about quite a big distance from the lesser curvature. So it's a stomach that has approximately, if you look carefully here, we size the stomach with a 40 dilator and stay 1.5 to 2 fingers from the dilator. So a lot of people say, oh, you use a 40 French bougie, so I'm making my sleeve 40 French bougie, and this is going to give a too small stomach with problems of protein. Read carefully. The bowel length, well, there was a calculation. There was a calculation of 40% of the total length. So he actually measured the small bowel, and you can see minimum in male and female was less than 5 meters, and maximum was close to 10 meters. So it goes between 5 to 10 meters, the average being 7 meters for total bowel. The interesting thing about Hess, and that's why we don't do the Hess 40% calculation, is that you can see here there is weight regain over time. And that is after 84 months, there is weight regain. And I think that the limb lengths are too long. And this is one of the problems why we prefer the Marceau fixed length intestine, is that we don't have this weight regain at this time with Marceau. We have a straight line with Marceau's data. And so when people ask me why, this is one of the reasons. Now the consensus, about 1/3 of people are now doing the new modification. That is a single anastomosis duodenal switch. So it's moving rapidly. The average body mass index in which we do them is between 50 and 60. So there's weight regain after sleeve. They tend to be more on the super obese patients. And that's the one who fail with sleeves. And actually, when you look at papers, and I saw that today, they look at conversions of sleeve and they have duodenal switch. The problem with this data is you don't know if they were 2 stages. Because very often we will tell the patient, comes into your office, I have a body mass index of 55, I'll do a sleeve, but you know, sir, we really think that sleeve is not enough. You're probably gonna get a 2nd stage duodenal switch later on. And so that often gets tabulated as a conversion and a failure of the sleeve, when in fact it's a 2-stage procedure with a duodenal switch. That is difficult in the BOLD and other data to see. The ideal common channel is between 100 to 150 centimeters. The team from Quebec, we have their other data being published here. You can see that type 2 diabetes remission goes, apart from SETI's paper, they're pretty high, between 87 to 93%. In terms of weight loss, it's also very high, in terms of 71% of excess weight loss at a very long period. This is the 20-year data. This is 20-year data, and I want to see any slides, any other operation in which from 5 years to 20 years, it's a straight line. There are no other operations. The BPD has some weight regain, and BPD is not the same as a duodenal switch. People confuse the 2 operations. You look at body mass index less than 50, they also have a straight line. Look at this up to 15 years, it's a straight line in percentages of excess weight loss. This is dramatic. So if we know we have a good operation for weight loss, then we have to deal with the side effects. Type 2 diabetes for that series resolution was 92.5% without medication. Hypertension 60% and sleep apnea was 98%. Long-term complication, there are some re-up, and this is some of the problem. There were some few patients with malnutrition that were readmitted. There were patients with incisional hernia for those who had open surgery. There are patients, even with that insufficient weight loss, there were 4 patients, and so forth. You have them listed here. Micronutrient deficiencies, they don't appear well in this slide, but there's a certain percentage of quite relatively low, because they are very aggressive at giving high doses of vitamin A and D, calcium and iron. So all those patients are on dose medicine at minimum. The ideal bougie size should be a larger bougie than what we do as sleeve gastrectomy if you're doing a first intention duodenal switch. And so it's up to 50 French. Some are using 60 French. The expected weight loss, as I said, is in the range of 70 to 79% at 5 years. The overall complication rate is, depending on the cohort of surgeons, between 5 to 10 or 10 to 15%. This is our near 10-year data from the Cornell, and you can see here that with our patients, our body mass index was 53, and it's close to 10 years. It's just a straight line from year 1, 3, 5, 7, and 9 in terms of body mass index. If we look at diabetes, we had close to 57% by strict criteria. We have 0 diabetic at year 7 and 9. Dyslipidemia, that's 1.9% by year 9. This is more of the cholesterol, the triglycerides, and this and so forth. It's a good operation for those hyperlipidemia. Body composition, for those of you who are interested in percentage of body fat, it is about between 27 to 30% body fat. It's the operation that brings down the percentage of body fat the lowest of any operations. SF36 before and after surgery, you have the, in this busy slide, you have the community norm, and if you look at 9 years, you can see that the numbers are identical to the community norm. So people say, oh, they have bad quality of life. No, they have excellent quality of life. And if you do follow them and correct their nutritional problems, it is a perfect operation. Complications after surgery from our series, you can see that they're very low in numbers in terms of leaks, surgical site infection, urinary tract infection, and DVT. You look at nutritional deficiency over years. This is year 1 up to 9 years, and you can see that our nutritional problem, as people don't come for follow-up, they increased over time, and this is the warning of that operation. Revision rate for weight loss failures, it is quite low, below 5%. And from time to time, we have a patient who has not lost enough weight or has regained some weight. And that's usually on the stomach size. The stomach has dilated, especially the upper stomach, and we will do a re-sleeve. So it's not a complicated revision for those procedures. And people agree, 85% agree that re-sleeve was a valid option. If we look at those who need re-sleeve, this is just for sleeve gastrectomy. You see that the volume has increased up to 400 milliliter in that series of Dr. Noel. And if it is more than 250, actually the proposal for sleeve gastrectomy. If there's reflux, then most of these patients with sleeve will go for gastric bypass. But if there's no reflux, and the volume of the sleeve is not that dilated, this is when we propose a DS or a CD operation. These are examples of the distension of the sleeves. Shortening the common channel for getting a better weight loss with duodenal switch is not a good option. We don't play with limb lengths. This is a dangerous proposal. It's been done before, and it has resulted in more nutritional problems and not better weight loss. Now, we have revision for malnutrition or too much weight loss, and that's about up to 2% in some series. And we do a side-to-side enterostomy. We actually do a lengthening procedure. You will cut, this is the common channel, this is all the 250 ileum to the duodenum, and this is the BP limb that comes at the 100. You will cut here and move this on this, so that now if you move an extra meter, you now have a common channel that has 200 centimeter, and you have a total length of bowel of 200 plus 150, that makes 350. And that should be enough for most patients to avoid protein and other mineral problems. There are other options. It's much more complicated, in which you want to reverse totally. You can anastomose, to the proximal gut and use the total length of small bowel. That is a reversal, except leaving just the sleeve gastrectomy. Now, in this consensus, people said that it's the most effective bariatric surgery for weight loss, and I agree with that, and as well for type 2 diabetes. This is the Chicago data comparing bypass and DS, and they have for diabetes, they had 100% resolution at the University of Chicago with duodenal switch and only 60% with Roux-en-Y gastric bypass. It's associated with a higher risk of malnutrition, yes, 100%. Now, the CD-CIPS does not have enough data, so right now we think that it's comparable to standard DS, but there's a lot of unknown, and that's the reason why right now it's going through an evaluation phase. Long-term complication, we're not sure if they're the same or more than duodenal switch, probably less. That is my expectation. So Dr. Torres is the one who made the single anastomosis duodenal ileostomy, and this is the operation that has 250 centimeter here. So you instead of cutting here and bringing this to create a common channel at 100, you don't do anything. You just do a loop anastomosis to the duodenum. And the problem is the bile comes up to here, and that's okay if the pylorus is competent. But if it's incompetent, it will bring potentially some bile up into the sleeve. And so long term, we don't know how many patients will have that problem and if it needs to be converted back to a standard DS by cutting here and bringing this to the last 100 centimeter. What we know is that this anastomosis, when it's done for diabetic at year 1, year 2, 3, and year 5, you can see that a remission after oral or remission after insulin, it is still pretty good, but I think a bit less than classic duodenal switch. It is done as a second step, and we saw the presentation before about this after sleeve gastrectomy. If you do that, this was a small series of patients. There was remission rate of diabetes was 88%, so pretty high and much better than just the sleeve alone. These are individual patients, and you can see that it reaches in terms of weight loss close to 73–72% of excess weight loss. And then here in the United States, the CIPS procedure, the difference is that it's a 300 centimeter instead of 250, and that's even slightly less aggressive. You probably would see less problems in terms of side effect and nutritional problems. They've compared the classic duodenal switch to the CIPS, and you can see there is slightly less weight loss compared to the classic duodenal switch. There is a question, this is at 2 years, and will it continue to diverge over time? I don't know. And in terms of diabetes, there's a small difference here between duodenal switch and CIPS here at 2 years. Still no patient were on any insulin in their own series. It's a valid option for weight regain. I think people agree with that, especially after sleeve gastrectomy. This is probably the best option for weight regain. And I come to the paper that look at the volume of a sleeve over time. You cannot do a duodenal switch 6 months later with a small sleeve. This is going to be a disaster. How much time should you wait? I think you should wait until the size of the sleeve is equal to what the masters made it for duodenal switch. And so, looking at this, we know that the volume of a sleeve that is made at 1 or 2 months, about 100 ml, will go up to 18 months, about 200 ml. So I would say that you have to wait at least 18 months, perhaps 24 months, before you want to do the bowel anastomosis, because then your stomach will be twice the size of what it was for a standard alone sleeve gastrectomy, and I think that stomach will be enough to handle the protein. I think it's the best option for type 2 diabetes after sleeve gastrectomy. These are some of the data from single stage to 2 stage from the University of Nice, and when the DS is done in 2 stages, the percentage of complication is less, and the weight loss is quite similar. This is 72.7 when it's done in 2 steps, and 73.3 when it's done in single step. So you don't lose the ability of getting effective duodenal switch by doing it over time. Failures of gastric bypass, well, it's a complicated proposal. I've done it in quite, piecemeal patients there and there over the years, and I think it's the best option for gastric bypass, but I would prefer not to do that. I would prefer that a lot of the super obese patients would in fact be candidate for duodenal switch or SADE rather than having weight regain and failure and then looking to do a duodenal switch later on these patients. So it's a patient selection issue in my opinion. Now the difficulty of DS acceptance is the technical difficulty. People don't know the duodenal switch, the duodenum and behind the duodenum in this area. It's like Canada. It's big, it's wild, it's cold, we don't want to go there. So the duodenal switch, I think it can be learned, it's not that difficult, it doesn't bleed, there's not a lot of problems. It's like doing a gastric bypass under less tension, lower in the abdomen. So can we remove this myth that it's a problem? There is more risk of malnutrition, people agree with that. Side effects, yes. But they're manageable, and now with lesser degree of anastomosis, I think it will come as a more frequent operation after sleeve gastrectomy and weight regain. I think that 100% of people agree that DS is a valid option for weight regain after sleeve. And don't remember that it's done by most academic centers in this country. Most academic centers are doing duodenal switch, so you should look into this and perhaps get some training. And I think to date, the DS is still out there, and it's now starting to come back, and I think that it has superiority for weight regain and type 2 diabetes after sleeve gastrectomy. Thank you very much.